All right. Hello, Dr. Church.
Right.
So today we're going to talk about just in general big picture anatomy of colon and rectum and the anus, and then how do we survey those and how do we look into them and try to diagnose diseases. So tell us a little bit about the anatomy of the colon and the rectum, not to forget the organ, the anus.
Okay. Well, I mean, we start with context. So the colon is an organ that's at the end of the small bowel. And what's its job? So its job is to take the products of digestion. So digestion is mostly complete, not quite, but mostly in the terminal ileum, and to transform those into a way that can be processed and stored and then eliminated in the most convenient way for us as human beings. So we're designed to get rid of the products of digestion once a day. In addition, because our designer knew that these products of digestion come from what we eat, and we put unbelievably noxious things into our mouth, the body has to be protected against what's in the colon. So in order to help with processing of everything that we might put in our mouths and come through to the colon, a whole flora of bacteria are built up in the colon as a normal way of helping to process the stool and helping to guard us against bad bacteria that we may eat. And as time goes by, the role of the flora in the gut is increasingly seen to be important in all sorts of diseases. So just by sitting there, these bacteria are doing lots of good things for us, and I think it'll become more and more obvious as time goes by and research happens. So in order to do what it has to do, the colon has to be a certain length, which is generally about 6 feet on the average. The rectum is generally about 8 inches at the bottom end of it, and the anus is about 2 inches at the very bottom end. So if we look at the different segments of the colon in terms of what they have to do, then we can see why they're designed the way they are. So the terminal ileum is the way that the stool goes into the colon, and it results in the ileocecal valve. It's a nipple valve that's designed to stop stool going backwards up into the terminal ileum. It doesn't seem to be that important because we can take that area out and patients don't have a major problem. But it is useful. We've just preserved that in a couple of patients that we took their colons out completely and preserved the ileal break. The terminal ileal area, which includes the cecum, is the apex of the lymphoid tissue in the bowel, and lymphoid tissue is very important in the bowel, partly as a protective mechanism for antigens that might be picked up in what we eat. The cecum, which is the expansion of the large bowel right at the very beginning of the large bowel, seems to act like a sump. So the liquid stool goes around the corner and up into the ascending colon. All the heavy stuff drops out into the cecum, where at the base of the cecum there's the appendix. So you could see that a lot of antigens would sort of be filtered out in the cecum, and that's why there's very high lymphoid tissue in the appendix especially, but also in and around the cecum. So the colon is distinguished from the small bowel by being a bigger organ and by the arrangement of muscles in the wall. We know that there's a complete circular layer, but the longitudinal layer is condensed into 3 straps or tinea, which help the unique peristalsis or segmentation of the colon. So, and that comes into play in the ascending colon, which is, I think of it as a butter churn. So it's supposed to take liquid stool, like milk, and turn it into butter or solid stool by the time it reaches the transverse colon. And so there's prograde and antegrade peristalsis, there's a churning movement, there's mixing. So the solid stool enters the transverse colon, and I think of the transverse colon as a conveyor belt. So little bits will be moved along, boom, 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 over to the splenic flexure. And then we're standing up most of the time, so as the solid stool rounds the splenic flexure, it drops down in the left side. And the left side of the colon, including the sigmoid and descending colon, is the reservoir for stool. And this is where the stool builds up, so that we don't go to the bathroom 100 times a day, we just go once. So you can picture the left side of the colon filling up with stool. In order to be a reservoir, the sigmoid colon at least has the thickest muscle, the strongest muscle, and it's where the highest pressures are generated. That's why pulsion diverticulae form there more than anywhere else. At the bottom end of the sigmoid colon, just above the junction with the rectum, there's a high pressure zone that keeps the stool in the left colon. And then once a day on the average, a mass movement will push all of the stool out of the left side of the colon into the rectum. So the rectum is normally empty. It's a big misconception that the rectum is a reservoir. It's not. And people think it is because we've designed J pouches to be quite reservoirs, and they are, but the rectum is not. So the difference is a reservoir has stuff in it. So a water reservoir has water in it. A poop reservoir has poop in it. The rectum doesn't. And the reservoir is the organ of, the rectum is the organ of defecation. So that when stool enters the rectum, a whole series of reflexes and sensations happens. And the rectal muscle squeezes, the anus relaxes, and it's almost automatic that the rectum will push the stool out. And in patients that are paraplegics, you do have automatic defecation, because any controls from above have been cut off by damage to the spinal cord. So when stool enters the rectum, what happens is now automatic, which is the anus relaxes, the rectum contracts, and out comes the stool. So it's really important to know that, because it impacts on what your expectations when we take bits of this mechanism out. What is the patient going to expect? And then at the very bottom end of the rectum is the anus, which, as we've talked about before, has functions to allow us to discriminate between liquid, gas, and stool within the rectum. So we may make decisions about what we get rid of or what we let go of, where and when.
I've heard sometimes about something called the sigmoid break. Is that something that does exist, or the sigmoid acts also as a reservoir?
Now, the sigmoid is definitely part of the reservoir. Yeah.
Okay. Is there a break mechanism in it?
Well, the rectosigmoid high pressure zone is the break.
Okay.
And then I think it's a very small length of bowel, right at the rectosigmoid junction.
Is there a value in preserving that in older patients if you're doing a total colectomy for some reason, or an extended colectomy?
Yeah, I think people tend to do that. I've done it myself, but when you're doing it for constipation, you have to be careful, because that may be the very thing that's causing the constipation.
Okay. If
you're doing it for cancer prevention, the important thing there, I think, you could leave some sigmoid, but you have to make sure you're not torpedoing your surveillance. So you might end up with somebody coming for surveillance of the retained sigmoid, and you can't get around the corner, or it's very painful, or you can't get the prep right there. It's much easier to survey just the rectum. But in patients that have issues with irritable bowel or abnormal stooling pattern, leaving a little bit of sigmoid is not a bad idea.
And now, if we divide those organs into 3 organs like they are, how do you survey them? How do you check for polyps or for cancer or for other problems?
Well, the colon's easier because it's colonoscopy, basically. The sigmoid also is sigmoidoscopy, or is part of the colonoscopy. And the essentials of that is you have to clean them out, and then you look. And for the anus, it's a little different, because generally you're not going to have an anesthetic for checking the anus. Mostly you're not going to want to check the anus. The most common reason to do that is this anal intraepithelial neoplasia, which patients can present with, which is really asymptomatic, and which needs anal biopsies and Sometimes this high resolution anoscopy, which doing it with acetic acid, you need the patient to be asleep.
When we're doing anoscopies, what are the different instruments that you can survey the anus with? Is it always a metal object, or you can survey it when you're doing your colonoscopy?
I think you can get a reasonable look with the colonoscopy,
Uh-huh.
but you have to be intentional about it. And it's easier to do it on the way in as well as on the way out. So inserting through the anus very slowly, and using the air and water insufflation button while you're doing it. The anus contracts and relaxes like any other part of the bowel. And it's important to be patient and hold the scope actually in the anus below the dentate line and just wait, and you'll see it will open up. So you can do a pretty good job like that. That's how I check the anal transition zone in patients with FAP. The other part of it is retroflexing the scope in the rectum and looking at the anus from above. And again, that's fairly straightforward in patients with wide rectums. And again, waiting for the anus to relax itself is important. That's important in colonoscopy to check the rectum out too. You often come down, the rectum is squeezed shut, and you can't see very well because the mucosa is so redundant that it's thrown up into folds. Easy to miss something. And so the trick is to just wait. And just wait. You want to finish the exam. You just got this bloody rectum. I want to check the rectum, and then I'm done. I'm going to have afternoon tea or something. But wait. Let it relax by itself, and you'll get by far the best look, and then pull out.
And then when we do surgeries, and sometimes you do reconstruction for patients, when we create pouches, we do pouchoscopies to survey them. There's so many goals for pouchoscopy based on the disease process, but I think thinking of patients with inflammatory bowel disease, pouchitis is the most common problem that we see, or we think it's pouchitis. So what does pouchitis mean to you, and how do you diagnose that?
Well, pouchitis clearly means inflammation of the pouch. So it's a vast topic, and there's a lot of misconceptions about it. So you can define it in three different ways: clinically, by symptoms; histologically, by biopsies; and endoscopically, by the way it looks. So symptoms of pouchitis, if you are defining pouchitis as similar to colitis but in the pouch. So what does colitis look like? The mucosa is red, erythematous, edematous, there's inflammation, there's pus, there may be ulceration. That causes irritability of the bowel, so you might expect more frequent stools. It causes bleeding if it's severe enough. The mucosa is fragile, so bleeding, frequent stools, and just general malaise. And in the colon, it causes urgency. The pouch, it shouldn't cause urgency. That's pretty uncommon. But if the patient has symptoms like that, then you look to see. They may have it. Much more common is a patient with those sort of symptoms. So a patient may get bloating, a patient may get nausea, vomiting, a patient may have frequent stools, but no blood. And this is where symptoms of pouch dysfunction overlap with pouchitis, because they're called pouchitis, but there is no pouchitis, no significant pouchitis. So there can be confusion clinically. There's also confusion histologically, because the normal biopsies of a completely normal looking pouch will show chronic inflammation with chronic inflammatory cells in the pouch wall. And this is because we're asking the small bowel to do something that it wasn't designed to do. We're asking it to hold stool. And when it holds stool, there's chronic inflammation in the wall of the small bowel. So you biopsy a pouch, it says chronic enteritis, typically. And then, oh, pouchitis. It's not. You can see acute active enteritis in a patient that actually has inflammation. That's different. But the chronic enteritis is normal for a pouch. And then there's the endoscopic appearance. Pouches get ulcers in them. This is part of when we make a pouch out of the small bowel. There's all sorts of staple lines there. There's all sorts of distortions of the wall. There's patches that don't have much blood and patches that have plenty of blood. And it's normal to see distinctive ulcerations at the entrance of the afferent limb and over staple lines. Those are normal. It's not Crohn's disease. It's normal. I've seen it called pouchitis and Crohn's disease and worse. But again, it's normal.